you very much. Is there any question or comment from the public? I think it was a very good introduction, and maybe we come back to you with questions which come up from the following presentations. Next, we will hear from Richard Carr from about the dream of or not the dream, the plan, the global malaria action plan for a malaria-free world. He is from the Rollback Malaria Initiative, yep. In Geneva.
First of all, I'd like to thank the organizers for inviting Rollback Malaria to speak about malaria at this important event. I would guess malaria used to be a neglected tropical disease, but in the last 10 years we can't really say that so much. It's gotten a lot of money. But even so, there's 220 million cases of malaria per year. There's about 650,000 deaths, so it's still a significant issue. Even though we've seen reductions over the last 10 years of about 25% mortality, and some countries have even done 75% reductions in cases and things as well. So Rollback Malaria Partnership is what it is. It's a partnership of different partners working against malaria. We started in 2008 or in 1998 as a way to work together to fight malaria because there wasn't much progress until that time. Or there was progress, and then people would let up their efforts, and malaria would come back into the world again. So our vision is ultimately a world free of malaria, but that's not going to take place in the next 10 years, probably somewhere down the line, maybe 50 years later. In 2008, the Rollback Malaria Partnership developed the Global Malaria Action Plan, which worked on targets, for example, achieving universal coverage by 2010 of different interventions, sustaining universal coverage indefinitely, reducing global malaria cases from 2000 levels by 50% in 2010 and 75% in 2015. So these are also part of the Millennium Development Goals, if you're familiar with those. Even more ambitious, though, that we're talking about global malaria deaths, reducing them by 50% in 2010 and near zero deaths in 2015. So we're going to try to go from 650,000 deaths right now in the next 2 years to near zero deaths, which might be a big challenge. Eventually, we're looking to try to eliminate malaria progressively in different countries, and eventually elimination or eradication of malaria completely in the world, but that might take 50 years, as we said. And we'll probably need new tools. So I'm actually not a nanomedicine expert, but I think what my goal is to sort of stimulate your thoughts about some ideas for research and hopefully interest you in taking forward some research on malaria, because I think we would all benefit from that. We've had a lot of success against malaria using various interventions. So we do target mosquitoes through vector control by using long-lasting insecticidal nets where people sleep under mosquito nets. Basically, the mosquito comes to feed on the person at night, lands on the mosquito net, and dies. We have indoor residual spraying where you spray the surface of the house inside with a pesticide. Mosquito comes and feeds on the person, and it needs to rest on the wall. It lands on the wall and dies. Then we also have some more limited things such as larviciding, and of course, in many Western countries, we might use repellents to keep mosquitoes from biting. When we target the parasite in terms of prevention, we look at chemical prophylaxis. So if you've ever gone to a malaria endemic country, you've probably taken some sort of prophylaxis. Also, maybe non-immune people going into an endemic part of their own country might take prophylaxis. We have IPT, which is intermittent preventive treatment for pregnant women. And then there's now seasonal malaria chemoprophylaxis to prevent malaria in children that live normally in areas where there's 4 months of very intense transmission, for example, in the Sahel region. And we've been working on a vaccine, but it's quite a difficult endeavor to make it work and make it effective and make it last long. So that's where we also need some help. For treatment and case management, we have rapid diagnostic tests. Obviously, those could still be improved. We need to work on other things. We have microscopy, which people have been using for years and years and years that they can distinguish the different parasites. We have treatment for uncomplicated malaria and severe malaria. We have effective drugs at the moment called artemisinin combination therapies. in the late 1980s, we started seeing massive resistance to chloroquine and different drugs like that, so we had to change drugs. These drugs are effective, but we've started to see resistance developing in the Mekong region. So we need to also, the good news is that we have lots of malaria drugs in the pipeline, as was explained, but we also have to be very vigilant to try to contain the resistance. We have two major types of malaria, falciparum and vivax. Falciparum actually is the one that leads to most deaths, we believe, causes cerebral malaria and things. But vivax is a type of malaria that actually can reoccur and can lay dormant in someone's blood for several years even without having symptoms, and then it reappears. So when we talk about interventions and we start thinking about it, we can look at the different life cycles. So you can see this is a life cycle of the parasite. We have multiple stages. So when it's introduced into the blood by the mosquito, the sporocytes, which then enter into the liver cell, replicate in the liver cell, release their moocytes into the blood, which then infect red blood cells, which then eventually release gametocytes, which are then picked up by the mosquito, which mature inside the mosquito's gut and then move to the salivary glands and then are retransmitted into humans again. So if you think about this, this is where maybe we can think about some ideas for research. Certainly in vaccines, if you want to create a vaccine, we could actually create vaccines at different points. So you could create vaccines that prevent the infection of the liver cell, or vaccines that prevent the infections of red blood cells. Or you could actually you could do a vaccine here, which doesn't help the person at all, but it helps prevent the transmission of malaria, which might be a new approach that they're looking at. Of course, then there's also the mosquito life cycle. So the mosquito, unfortunately, it's only the female mosquitoes that bite, because they have to they feed on blood to incubate their eggs, and then they lay eggs in the water. So So you have it here, they lay eggs in the water, then they have a larva and a pupa, and it turns into adults. And then they mate again, and then they complete the cycle. And as I said, these were some targets also for the vaccine, so you can target the different sites here: liver, blood, or mosquito stage. I was just talking about some other interventions, and I've been inspired by some of the presentations I saw about liposomes and things like that, where you might be able to put a chemical that's toxic to the mosquito or to the parasite into a liposome or something, and then when it's picked up by the mosquito in the blood, it goes in the mosquito's gut and opens up and kills the parasite there. That might be an interesting approach, and I know Professor Hunziger mentioned that they're actually working on an approach such as that. In terms of areas for research then, one of the key issues is to have a single dose, radical cure of malaria, which impacts all species and all life stages. So kills falciparum, kills the vivax, kills all those different life stages that we talked about. So that's one of our challenges. We'd love to have that. Obviously, we need new drugs and therapies, especially if resistance continues. We need new drugs that might target the gametocytes, because they can actually block transmission of malaria, so that we end up not having, especially for countries moving to elimination, if you can block transmission of malaria, that'll have a huge impact. Diagnostics, one of the issues is, you saw that in the slide previously, not in my presentation, but in the other with the healthcare center, and these are the kind of centers, these small centers. I was in the south of Sudan, and they actually had a mud hut with a roof, and you go in there, and you can imagine the type of facility. There's no running water, there's no electricity. So we need to be able to come up with simple diagnostic tests to distinguish between the causes of fevers, for example, malaria, versus a respiratory infection caused by bacteria, versus septicemia versus dengue. Something, if you could screen like that quickly, you could save many lives, because then you could go to a better treatment quite quickly. What happens in a lot of countries right now is that someone comes into the health center with a fever, they assume it's malaria, they give them anti-malarias. But that misses a lot of the other fevers, and we need to work on ways to distinguish that. When you're going to elimination, you want to know if you have imported cases or locally acquired cases. One of the medicines for treating vivax, because vivax has a stage that hides in the liver, as we mentioned, it's called primaquine. And you can't take this drug if you have glucose 6-phosphate dehydrogenase deficiency, because you'll actually die from the primaquine. So we need to be able to screen that before we treat people with primaquine who have Vivex. Also, diagnostics that measure gametocytes, so we can measure the actual transmission levels. In terms of the human environment, we need vaccines, including transmission-blocking vaccines, which we mentioned. Substances to boost immune responses. So I saw like adjuvants and things. Maybe we can work on things like that actually help to boost the immune response. We need to understand better the factors that lead to disease, severe malaria, and death, because you start with 400 infectious bites, you get 200 clinical cases, or 200 cases of infection, 100 cases of infection, clinical symptoms, and then you get 2 severe malaria and 1 death, so we don't understand why that works that way. In terms of the mosquito environment, so we need to think about substances that impact parasite stages in the mosquito, substances to shorten mosquito lifespan after they attack you, because the parasite takes about 10 to 14 days to mature inside the mosquito. So if the mosquito dies 7 days after it bites you, it won't transmit malaria. New pesticides. They've been working on genetic manipulation of mosquitoes to make them sterile. Another company has been working on blocking the sensory mechanisms, for example, CO2 receptors, which allow the mosquito to sense the human prey. We also need to work on improving the efficacy of current interventions, so new drug combinations or pesticide combinations, longer lasting pesticides that last longer time on the wall once they're sprayed or in a wall hanging, substances or mechanisms that interfere with the drug or insecticide resistance mechanisms or counteract the G6PD deficiency. Effective repellents may be substances that can be ingested by humans, or long-lasting substances that can be impregnated into clothes, bedding, etc. And time-release medicines, prophylactics. Because, for example, primaquine, you have to take 14 days. You take 14 doses over 14 days, and it's very hard to get people to adhere to to that sort of schedule. So if we could have something that releases medicine over that period so they could take 1 dose, I think that would be very helpful. Anyway, that's all I have. I was just to put some ideas out there, maybe hopefully to stimulate some research in malaria.
Thank you very much. Are there questions? Are there ideas? Yes?
This may be a simple question and everyone knows this, but exactly what cell in the liver is it resident in? The Kupffer cells, the hepatocytes?
I don't know, maybe do you have information? I know that the problem with the hypnozoites is that it's kind of not very well understood how the Vivex, for example, goes into its dormant stage. In terms of the specific cells of the liver, I wouldn't say I'm an expert on the liver, so I don't have an answer to that. But maybe someone else has an answer to that.
Well, I think they enter through Kupffer cells, what is the hepatocyte. Sorry. I think they enter the liver through the Kupffer cells, but the cell which they infect is a hepatocyte.
But could they actually be resident in the Kupffer cell? Because if you look at HIV, Kupffer cells and microglia are actually where you see a lot of dormant virus.
I don't think so, but I am not 100% sure.
Yes, the resident stages are all in the hepatocytes, though the macrophages are not the reservoir which is relevant. So finding out about the cellular biology of infectious hepatocytes versus normal hepatocytes, in particular also for Vivox, would be a real advance, but this is a little bit challenging, but it certainly would be one of the doors to open this field. Okay, so thank you.
You have a question?
No, I just wanted to complete, in terms of chemistry, preventing means preventing the proliferation, respectively transforming hematine in hemozoin, which is malaria pigment, which is an insoluble structure, and it's difficult to get to the mechanism of forming this. which means consequently to find the proper drug to inhibit the polymerization. Thank you.
Okay.
Does somebody want to answer this question?
So, if I understood your question correctly, you're asking if there are
It was not a question. I tried to answer in terms of chemistry to what.
Oh, I see. Okay.
About the Plasmodium falciparum.